Hi, everyone. This is Trisha Ong with Johns Hopkins School of Public Health. Thank you for joining us today. We're excited to finally launch this Data for Nutrition community of practice. Our team, Data Dent, has been working with stakeholders over the past year to set it up. And we're excited that we're in the soft launch phase. During the soft launch phase, we are hoping to test out different features like the webinar, like having quarterly webinars. So we're launching off today with a webinar called New Data for Nutrition Updates to DHS 8 Questionnaires, which will focus on the new nutrition content that will be introduced during the Round 8 DHS program. Before we get started with the webinar, we have some housekeeping rules to help keep things on track. So during the presentations, we will mute all participants. If you have questions, you can submit them through the Zoom platform. There's a button called Q&A at the bottom of your screen. And these questions will be sent to our panel moderator. We will try to get to as many questions as we can at the end of presentations, and a recording of this webinar will be added to the Data for Nutrition community of practice after we conclude. If you're still having trouble with access, feel free to email Riley her email address is right here, and we'll do our best to respond during the webinar and follow up with you afterwards to see if we can resolve your issues. So once again, thank you for joining us during our soft launch. We will be using this phase to gather insights from community members on what's going well and what's not going well. After this webinar, we will have a discussion post on the main page to get feedback from you. So we'd appreciate if you could share your experiences working, using the community of practice at that point. Another note is within the Data for Nutrition community of practice, we have it structured currently with 6 different groups. So this provides an overview of what each of the 6 groups are. The webinar group will be added later today. And so from going forward, we will be hosting our webinars through this group within the community of practice. We also wanted to highlight for you that you can individually customize your notification settings. So when you are logged into the Mobilize website in our community of practice, if you look at the top right, there's a settings option under your user profile, and you can set certain email notifications for different groups that you're a member of. You can also customize your notification settings directly from emails that you may be receiving from the community of practice. So today I'm excited to share that we have 3 speakers. The first is Sorrel Namaste. She is the Senior Nutrition Technical Advisor of the DHS program. Erin Milner, who's Nutrition Advisor of USAID. And Olutayo Adeyemi, who's an Assistant Lecturer at University of Ibadan, who will be speaking on the experience of adding MDDW to the Nigeria DHS 20. Erin, would you like to get started?
Sure, thank you. So I'm going to provide some brief background and an introduction about DHS and the DHS updates from the USAID nutrition perspective to get us started. The DHS program has been led by USAID since 1984, demonstrating USAID's long-term investment in quality global data. It has provided technical assistance to over 400 large-scale nationally representative surveys in 90 countries. DHS currently collects data to calculate 30 SDG indicators, including many nutrition indicators, but also many others that go beyond nutrition. The DHS program surveys are country-owned and implemented generally by national statistics organizations with technical assistance from the DHS program. DHS is one of the top sources of nutrition data globally, highlighting the importance of continuing to strengthen nutrition data quality, collection, and availability. So the DHS program has 5 key results areas, all of which are critical for nutrition. And these are the sort of areas that the DHS program focuses on. The first is improved tools, methods, partnerships, and technical guidance to collect quality data. An example of this is the variety of anthropometry data quality tools that were developed in the past year. The second result area is one of the most important. It is increased in-country capacity for identification of data needs and for survey design, management, and data collection to meet those needs. Examples of this include a nutrition e-learning course, nutrition capacity building workshops, and the DHS Fellows Program. Another key focus of the DHS program is improved availability of DHS data and information. The fourth area is advanced analysis and synthesis of DHS data. Examples of this include analyses of adolescent nutrition and linking the service provision assessment, or the SPA, health facility data to DHS household level data to analyze how health facilities support iron and folic acid supplementation adherence and early breastfeeding. The final key result area is improved facilitation of DHS data use worldwide. Part of this data use component is sharing with you all today some exciting nutrition updates to the DHS questionnaires. So with that, I will turn it over to Sorrel to share more.
Actually, while we're waiting for Sorrel and figuring out these technical difficulties, maybe we can move on to Tayo's presentation and then come back to Sorrel's presentation afterwards. So Olutayo Adeyemi will be speaking on how the MDDW was integrated in the Nigeria DHS 2018. So this was done before MDDW actually became part of the core questionnaire for round 8. So we're excited to hear about this experience of how MDDW was integrated, and then also the results, the MDDW results, which were released in the DHS 2018 Nigeria report a couple months ago.
So I'll be speaking about the motivation, what led to the decision to integrate MDDW into the DHS and the stakeholders that were involved. Okay, so Nigeria has a high burden of undernutrition, and there's a lot of data that is collected around health and care practices and sanitation. So apart from the DHS, there's a mixed survey, and then there's a national nutrition and health survey that is conducted annually. And these are representative studies that surveys that collect data even at the level of the 36 states we have, and then the 6 geopolitical zones. And so the key missing part was food security data. And Nigeria hasn't conducted a food consumption survey or a dietary intake survey in about 20 years. And the only survey that has been conducted, the full report has never been formally released. And so there's little to say what people are consuming and what diets look like. And so when the MDDW came out, there was a push to include it in at least one national survey, but preferably more, particularly the one that is conducted annually, so that we could see what people were eating and have an idea of where the gaps. A big push for integrating the MDDW into the DHS came from the Ministry of Agriculture. Now, because the DHS is a health survey, or predominantly a health survey, it is managed by the National Population Commission as well as the Federal Ministry of Health. And so the Ministry of Agriculture was not even on the table at all for discussions around the DHS. But because of the interest in including MDDW, several partners came together. FAO was key in the process because FAO had introduced this indicator in country at the end of 2015. And so with GAIN and then BMGF, these 4 partners worked through the Ministry of Health and then later through the National Population Commission to push for the inclusion of the indicator in the DHS. And so initially there was some resistance from the health sector because they had said that the DHS was already a very cumbersome survey and they were hesitant to include another indicator. But after the justification that dietary diversity data had actually been collected in a previous DHS, but then it was discontinued. And so we just advocated that, okay, it's like bringing back an indicator that has been collected before, but with the advantage of having a standard to measure the indicator. And then the indicator is also useful for planning how to scale up the several micronutrient deficiency control programs that are ongoing in country. DHS were just released in November. So this is really new data, and it was very exciting to see the MDDW results in particular. And so what we found was that nationally, more than 40% of women are not meeting MDDW. So this means that they are at risk of inadequate micronutrient intake. And then we have the prevalence being higher in the rural areas than in the urban areas. In the urban areas, about 40% of women are not meeting MDDW, and then in the rural areas, it's nearly 50% of women that are not meeting MDDW. And then when we look at the geopolitical zones in the country, we see that the southern zones, there's a higher prevalence of percentage of women who meet MDDW in the south than in the north, and part of this goes to culinary practices in the north and the south. In the south, mixed dishes are very common, and so people put a lot of things together when preparing even single meals. So this is not to say that the amounts of the foods being consumed or the different food groups being consumed are very significant, even though the MDDW has a cutoff of about 15 grams. We know that in terms of amount, women may need a lot more, but in terms of whether or not they're consuming the food groups, yes, we can see that more women in the south than the north are consuming the food groups. Okay, and this slide again shows the percent of women who are consuming food groups, but now by wealth quintile. And there's a very, there's a marked gradient from the lowest quintile, wealth quintile to the richest. But one thing that's very striking is about 1/3 of the richest women are still not meeting MDDW. And so this is showing that, I mean, this gives an indication that there's probably a very big need for nutrition education, even among the rich, if we have this proportion not meeting MDDW. I don't have the results on the slides, but for by education level, 30% of women who have more than a secondary education, that's more than a high school education, are not meeting MDDW. But if we were to take the prevalence between the richest quintile and the poorest quintile, we can see that even if we were to scale up nutrition education, there's still going to be a proportion of people who cannot meet MDDW because they are food insecure or for other reasons that have nothing to do with education. Okay, and then, so apart from the looking at what percent of women met the MDDW of 5 or more food groups, it was interesting for us to see what's the percent of women that were consuming different food groups. And what we realized is that certain nutrient-dense foods were being poorly consumed. For instance, just 16% of women consumed eggs, 20% consumed dairy, and then even fruits, just about 36% of women had consumed fruits the day before the survey. But we also found out that with 20% consumed dairy, yes, but about 22% actually consumed sugar-sweetened beverages, and then you have 15% consuming sugary foods, and then 19% consuming savory and fried snacks. So the data is showing us some of the reasons why Nigeria has this high prevalence of micronutrient deficiencies among women, but also providing some indication of what women are consuming that may also be driving the increase in overweight obesity, and that has been increasing steadily over the last 15 years. Okay, and so so this data is new, and so we haven't started exploring the raw data, but we hope that we will be using this data to explore factors that are associated with the different consumption patterns, including whether or not a woman meets MDDW. And then we'll be looking at linking consumption patterns to anthropometric indices to see, I mean, MDDW is a relatively new indicator, so there's not much out there in terms of, even though it has been standardized for micronutrient intake, just looking at how it's associated with other nutrition variables is of interest to us. And then we'll be triangulating with other data to gain insight into what the local food systems are. We know that people's behavior, what they consume, is related to their food environment and other food system factors. So we'll be trying to see how the data can tell us something about this. And then we'll also look at, now we have the mother's intake and the child's intake in terms of dietary diversity. We'll be comparing these two pieces of indicators to see where the gaps are vis-a-vis infant and young child feeding practices versus household, what the household has in the house. So if for instance, a woman consumes meats and poultry, but the child does not consume those kinds of things. And then the final thing we'll be looking at is combining the MDDW information with micronutrient supplementation data to identify the areas that are most likely at risk of micronutrient deficiency. And that's my last slide. So thank you very much.
Thank you so much, Tayo. This was really interesting, and it's really exciting to see how MDDW was used in Nigeria. For all participants, just a reminder, if you have questions for Erin or Tayo, you can submit them through the Q&A button at the bottom of your screen. So next we're going to go back to Sorrel's presentation. I think we have all the technical glitches figured out. So Sorrel, feel free to share your screen.
Thanks everyone for being here today. I'm going to be talking about all the new and exciting information we're now going to be collecting as part of the DHS program. Thanks, Tayo, for your presentation. It really highlights the type of data that is useful for us within the nutrition community, and we'll now not just have that type of data in Nigeria, but we will now have that in all DHS surveys going forward. So first slide. Within the DHS program, we align with the same objectives that Erin presented. Where we're really focusing our efforts is around improving data quality for nutrition, increasing data use, exploring innovations, and building capacity. So a little bit about how we go about standardizing DHS data. So we have core questionnaires that are updated every 5 years. And this is essentially when we do support a country to do a DHS survey, this is their starting place for what goes into their survey. And a lot of you may have heard of the household, the women, the mans, the biomarker questionnaire. We also have a field worker questionnaire that provides information about the people that are actually collecting the data. And then in addition to these core questionnaires, we also have optional modules that countries can select and add to their survey. So the length of the DHS-7, which was the previous 5-year period, was a long questionnaire. So there's around 700 questions across all the questionnaires. For the women interview alone, it would take about 45 to 50 minutes. They were also the same people who were often the people answering the household questionnaire. So it's certainly a lot of time that we're spending in a household, because in addition to the questionnaire, we're also doing biomarkers. Next slide. So what that means is we really, when we go about making changes to the core questionnaire, we need to make sure we're meeting existing and emerging data needs. We also need to make sure that we're maintaining quality and not overburdening the survey with too much information, which is why often the core questionnaires change very little over time, because there's only so much we could include in the survey. And just as important, we really want to make sure we can maintain trends over 20 years. So there's actually many questions that we started collecting in 1984, and we're still asking those questions the same way now to be able to track progress over time. So every 5 years when we update the questionnaire, next slide, we go through a very rigorous process to make those changes. So for DHS 8, we started that process last fall, winter. And first we sought external stakeholder feedback through the interweb, where we asked for open comments. There was a lot of responses for nutrition. Data then played a very large role in helping submit external stakeholder feedback on what would be useful for nutrition. We got a lot of submissions for many other topics besides nutrition as well, of course. After we received these external stakeholder feedback on what they saw as the priorities, we then internally at the DHS program set up internal committees for each topic area in which we reviewed every single question that was submitted and determined whether it made sense within to include within the context of DHS. That then went to a higher level DHS review committee that took all these questions and considered them in their entirety. At the next phase after that, suggestions were submitted to USAID Washington, and USAID made reviews, comments, we made additional revisions and feedback, and then we released the DHS 8 questionnaire this fall. We received over 1,000 pages of materials of suggested new data to include within the DHS program. There was 954 new questions that were requested. We received feedback from all over the world for within the review portal that we have set up. And within that, we actually deleted a number of questions, but we added a number of questions as well. So we added a historical 183 new questions to DHS. So for nutrition, out of that 1,000, we received around 125 pages of suggestions. Within that was 71 questions. In the end, we actually added 39 new nutrition questions to the DHS program, which is a substantial amount of new information related to nutrition specifically. We also deleted a few questions that the nutrition community felt were no longer relevant or were duplicative of other questions within the questionnaire. And we, in terms of modules, we also have accepted a module on food insecurity, which is actually one of the SDGs, so the SIEF. To put it into perspective, we had 54 nutrition questions in DHS 7. That's gone all the way up to 89 nutrition-related questions in DHS. This is within the women questionnaire alone. We have made changes that apply to many questions within the DHS, but definitely also apply to the nutrition questions around the recall period. So our reference period had been 5 years, for example, for iron folic acid supplementation. We've now reduced that to 3 years to improve the quality. We also have a biomarker questionnaire, and there's 2 standard biomarkers that are included within that questionnaire within DHS 8 that were also in DHS 7, and those are anemia and anthropometry. And within the questionnaire, we've included new information to help us better interpret that anthropometry data, which I'll talk about in a minute. And then, as I mentioned before, we also have this optional food security module that countries can include within their questionnaire. So looking across the life cycle for women, we now have new data around clothing and hairstyle interference within the biomarker questionnaire for anthropometry. And while at this point we're still looking into how exactly that information will be used, it's an important next step to help us in interpreting our anthropometry data. We have new questions around the coverage of breastfeeding counseling during ANC, as well as around nutrition counseling during pregnancy within ANC. We also have included for countries that have large-scale cash assistance programs for pregnant women a question on that specifically. And then we've added for iron folic acid supplementation, the source of where you're getting your iron, so at a health facility and so forth. And the really big one that we've added for women is minimum dietary diversity. So this is being collected not just in pregnant women, but in all women within the survey. And this is around 20 questions that have been added to get at dietary diversity for women. And it includes both healthy and unhealthy food groups. For very, very young children, we'd already had a lot of data. So as you can see in the gray, this is already the things that were being collected for very young children. So the big difference between previous DHS 7 and DHS 8 is that we also for anthropometry have the clothing and hairstyle interference, and we've really maintained all these other questions around feeding practices and counseling during very early childhood. And then for children, we've added a number of questions around nutrition coverage of interventions. So one thing that's really important is we now have can collect data on nutrition counseling in young children for the infant and young child feeding practices. We've added to the infant and young child food practice unhealthy eating questions around consumption of sugar sweetened beverages, as well as consumption of snack foods, so like things like fried foods. And so now we'll be able to not just track the healthy eating patterns of children, but also the unhealthy eating patterns of children. And we've included a nutrition coverage indicator on growth monitoring for children as well. So whether that's via MUAC or weight or height. So for children, one thing that's very exciting is we now have all these coverage indicators that we didn't previously had, in addition to the other data that we've collected in the previous DHS 7. We've also modified slightly the iron supplementation question for children. So it previously had been, have you had, iron in the previous 10 days? It's now actually in the previous 12 months to better align with WHO recommendations. And we now can also distinguish between the iron vehicle, so whether it's a pill or it's a micronutrient powder, so that will give us additional information in countries. So in addition to now having 89 nutrition-related questions in the Women's Questionnaire alone, we also are doing a lot to ensure that it's not just more data, but it's better data. And so I'm highlighting a few examples here. So for anthropometry, we've been working really hard to improve our standardization exercises that occur during training to be able to assess the precision and accuracy of the trainees before they go out to the field. And so we've developed a whole slew of materials that are now integrated within the DHS program to enhance standardization, whether it's materials that are targeted to the statistics office and countries on how they can improve anthropometry data quality, all the way to in-house trainings on anthropometry measurement among our own staff, so they could then become gold standard measures that go to the field and do the trainings for the field workers. So we've made a lot of progress in this area, and we're continuing to do that as we move forward. One thing that is also very different in DHS 8 compared to DHS 7 is for infant and young child feeding questions around the food groups. We now have a much more, there's a lot more adaptation that is being required. So the example I'm showing in this slide is previously we would ask, okay, like, did you eat bread, rice, noodles, porridge, or other foods? We now have this, for pretty much every food group, you actually insert the commonly consumed foods from that country. Now, this is not intended to be an exhaustive list of every single thing that people possibly will eat in a country, but it does mean we will be picking the top, 3 to 6 food items that are consumed in the country and inserting those throughout the questionnaire. And in order to ensure that the quality of this is carried out well, we've been developing adaptation guides for DHS to figure out what is the best way to adapt these questionnaires within countries while still maintaining comparability across countries. And we're working on a number of trainings to help us do that adaptation process for the infant and young child feeding practice questions. This also applies to the MDDW, and we learned a lot of lessons actually from the Nigeria experience, in which we were trying to create a rather exhaustive list of different food items, and now we're realizing that people the respondents don't listen if you, list 10 or 15 items, and so you pick those most common within a country. But of course, that requires a lot of work working with within the implementing agency and with others in the country to make sure that we're picking the right foods to go into those different food groups. And then the last thing that we've been really focusing on in terms of data quality is around measurement of anemia. So We have been collecting hemoglobin since the mid-1990s. We follow the current HemoQ point-of-care technology, but as more research is coming out, we are realizing there may be variations in hemoglobin concentrations depending on the quality of the blood sample and if it's venous or if it's capillary blood. So we're actually going to be piloting in this coming spring different methods of collecting hemoglobin data to make sure that we are using the best method possible that is valid and going forward. So in addition to this hemoglobin pilot, there's also a pilot for the DHS 8 questionnaire as a whole, and so a number of questions that are related to nutrition, but also related to other topics will be piloted in a questionnaire format in this spring. And so people I know are really excited. Okay, like we now have all this nutrition data. When are we going to start using it? Essentially, what is happening now is we're developing all the systems with this new DHS 8 questionnaire, which means, you know, getting our data processing system running, getting our questionnaires set up to be able to be collected electronically. And countries who are starting out now will be able to use the DHS 8 questionnaire, but surveys that were, you know, midstream are still using the DHS 7 questionnaire. Once we pilot these questions, there may be some modifications that are made as we go along to better improve the wording of questionnaires. But the pilot is not intended to be validation because the questions that we've selected are already considered to be the appropriate questions to be asking. So it's more around, you know, changing the language here and there to, and we'll be doing interviews both with the respondents and with the interviewers when we do this pilot testing to make sure we're asking things in the right ways. What's also exciting, and I think that we haven't been talking about quite as much, is not only do we have a lot of new nutrition data, but we have a lot of new data on many, many different topics within the DHS program. And that data can actually be linked to DHS, and we could do analyses that we really previously couldn't do before because the data didn't exist. So I'm just throwing up on this slide a few examples of the type of data that we are now collecting that might be interesting to look at alongside the nutrition data. So we have things around household energy sources. We now are better able to measure stillbirth. We have a lot of information about respectful maternity care. So for instance, we could look at iron supplementation in relationship to respectful maternity care or in relation to nutrition counseling. We have gender questions, which I know for food and nutrition, it's really important to understand women's workload in relation to care. We have menstruation hygiene questions within WASH, and we have more health system questions. And this is just an example of the depth of new data that's being included within the DHS program. So there's going to be a lot that we could do that's both nutrition and nutrition related. So we're really excited to see the new types of research and analyses that can come out of that to help shape policy and programs. So this is just a plug that we do have a great dissemination team here, and we do share things about the DHS program as a whole, and we also share information that's very specific to nutrition. So if you check out on our website, we'll often be releasing blogs on the type of work that we're doing. So up on the slide here, we have examples of linking our facility-based surveys with the household-based surveys for nutrition questions. We have here a piece around data quality within Nigeria for anthropometry. And we have, other types of data quality work we're doing across nutrition to strengthen the data that's collected in the DHS. And there's actually a newsletter that you could join to receive information on these blogs, as well as we release a newsletter once a year that talks about the work that we're doing within DHS for nutrition. So if you go to the DHS website, you could join that newsletter. All right, thank you. So that's it for me. I'm happy to take questions.
Great, thank you so much, Sorrel. The first question that came in is for Tayo. In terms of the Nigeria MDDW experience, do you have a sense of how many meals women are receiving per day in Nigeria?
Hello?
Oh, yeah, we can hear you.
Okay. Yeah, so the MDDW does not include the number of meals. So as far as I'm aware, the number of meals were not collected. It's a dietary diversity. It's pretty much yes, no. Did the woman consume this particular food group?
Thank you so much, Tayo. So the next question that came in is for Sorrel, is if you could explain a little more of what you mean by hairstyle interference.
Okay, so let me give you a few examples. So in children, we recommend taking off as much clothing as possible, if possible, for them to just be in their underwear. But there's cases where that's not possible. Children are not even wearing underwear, and you can't take all the clothing, or the participant refuses to take off the clothes, especially in cold areas. And while we then try to, mitigate that with things like putting blankets on young children, it's not always possible to weigh people with almost no clothing. And so the interference, so essentially the field worker would mark down if the person was not dressed down to a minimum, whether it's a child or a woman. And in women, this really matters. Like a good example is in Guatemala, where clothing is extremely heavy, and you're not going to ask women to take off their clothing. For hairstyles, we often find people, have elaborate ornamental hairs that could add a lot of, up to, an inch or two on top of their head. And you're not going to ask someone who's, spent a lot of money putting their hair together to take out a hairdo. And so that means that you end up having people seeming taller than they really are, both children and women. And so what we will be now collecting is information on that situation. Now, we don't know how are we going to handle that. How are we going to put some sort of adjustment? Is there going to be a global adjustment? Should there be a country adjustment? But at the very least, we're going to begin to understand the problem and know to how much interference there is. And these new questions are actually aligned with the new WHO UNICEF guidelines that have come out around anthropometry data quality that was released this spring. So we're aligning with them on that, but just like we aren't sure yet how to use that data, there hasn't been recommendations made yet on how to do so.
Thanks so much, Sorrel. So our next question is, has it been considered to collect nutrition data for school-aged children?
Sorry, I was getting off of mute. I mean, I can start and you can add to it, Sorrel. I mean, currently the DHS does not collect data on school-aged children for a variety of reasons. I mean, as Sorrel mentioned, that adding 2 questions can also add to the burden of the survey, but also this is a very challenging age group to collect data on for ethical and logistical reasons. So while it has been considered, and I think adolescents are of growing interest, as of now, it's not been part of what the DHS covers. Sorrel, do you have anything to add?
No, I think that's a great summary. I think the only thing to say is right now, the way DHS works is we are going household to household to collect this data. But when you add in school-age children, you need to start thinking about different platforms, such as going to schools to collect data. And so it really does change the nature of what we would be doing in clusters. But agree that this is needed data.
Thanks so much. Our next question is, can you tell us what methods will be piloted for hemoglobin collection? And this would be for Sorrel.
Mm-hmm. Sure. So this is actually under a larger project that's being led by Advancing Nutrition USAID. There's a hemoglobin working group that's been put together, and a group of global experts have come together and have been developing a pilot to better understand this hemoglobin variation. And the DHS is going to be one of the study sites that tests these things out, and we're going to be thinking about it from the DHS context when we do our piloting. But essentially, as of now, and we're still in the development phase, we're going to be looking at differences between single capillary blood, so you take one blood drop, versus pooled capillary blood, in which you take many blood drops, but still it's capillary, versus venous blood. And what we want to do is we want to look at that both in a controlled lab setting, and then we want to look at how that plays out in the field. So when we pilot the questionnaire, we also will be going into those households and we're collecting hemoglobin data, and we'll be doing comparison groups for each of these different types of blood samples.
Thanks. So we're getting quite a number of questions that are very specific about the MDDW in terms of food lists. And so we'll go ahead and actually answer those questions through typed responses, which will get posted, because I think there's quite a bit of interest, and I'm sure that was sparked by Tayo giving us a bit more of a presentation. And some of these are quite technical about the number of groups and how things get collapsed. And also, I think Anna Hareforth has shared an interesting comment related to some related work. So given the interest, and we actually do have a plan, hopefully next year, to do something more in depth on MDDW as well. So, but we will answer those questions because we know they're important and there's so many of them.
And so I have one final question that I'd like to pose for all panelists. So everyone on this webinar right now are passionate about nutrition data. And so one thing I'd like each of the panelists to weigh in on is, how can we as a nutrition community encourage the use of this new DHS data, and what we can all do to help support it? Because as we know, we don't want this nutrition data to be lost after the next revision. So maybe Erin, you can start, and then Sorrel can weigh in, and Tayo as well. So Sorrel, you're currently unmuted, so maybe we can try Sorrel first and figure out if you can unmute Erin.
Well, maybe I could summarize a little bit about what the DHS program is doing as a whole to promote data use. And then we also have some very specific nutrition workshops as well. So we support a number of capacity building activities, and we hold a number of workshops around the world every year. And they're targeted at different audiences. So we have something called like the DHS Fellows Program, and that's targeted at researchers who actually identify a research topic and publish a working paper on that. We have workshops that are targeted at policymakers and how they could use the data for programmatic purposes. And very specifically within for nutrition, we've been developing an e-learning course which helps people see the type of data that's being collected on nutrition within the DHS, help them interpret the tables so that they could be thinking about how they could use that for policy and programmatic purposes. And we've also been considering trying to develop actually workshops in country that in addition to the e-learning course, to promote the use of nutrition data in the countries where we're collecting the data. So that's one area that can help promote data use within the DHS program. So I think that would be, from our side, some of the big areas that we're working on.
Thanks. I'm repeating this question because we had some technical issues, but the question is related to how we can encourage the use of the new nutrition data in DHS. So Erin, would you like to share some thoughts on that?
Sure, thank you. So we at USAID are also sharing this exciting information about the nutrition updates to the DHS internally and in Washington, but also with our country offices. So we are excited about motivating our country offices to use this new data to also inform their programming, their work with country governments and country partners to inform policy decisions as well as new activities. So we're creating, several sort of briefs and also reaching out to these counterparts to further promote the use of this new nutrition data.
We're actually running out of time, so actually we're going to ask Tayo to share her thoughts within the webinar post.
We'll help you with that, Tayo.
Particularly because I think people will be interested in how the MDDW has been received in Nigeria and how the data will immediately be used. So we'll help you with that, Tayo. But I just want to thank everyone again for joining us for this soft launch of Data for Nutrition and our first webinar. So when the webinar concludes, we'll have a couple of questions posted within the event page. And we would love it if you could share your feedback on how things went today. We know that there are some technical glitches, and so we're hoping that we can fix them before the full launch. But we would appreciate any feedback you have so we can improve things. We also will have, as I mentioned earlier, a discussion post on the main page where we'd like you to share feedback on your general experience with the community of practice. If you're having any issues with navigation, and we'd like to hear them now so we can definitely improve them before the full launch. So thank you so much to our speakers, Erin, Sorrel, and Tayo, and everyone for joining us today. A recording of the webinar will be posted within the community of practice, and we'll send a message when that is posted. Happy holidays. Thanks.